Hi guys, welcome to my YouTube channel. I am DOCARANAS, a fourth year medical clerk, and I basically provide informative videos to medical students. And also, I would like to give aspiring Filipino physicians an idea of what a medical student usually tackles in med school. If you find this video helpful, please don't forget to hit the like button and subscribe to my channel and click the notification bell to be updated for my new videos every week. In this video, I'll be discussing the adult head-to-toe physical examination, and this is dedicated to new members of MOMFI as part of the Volunteers Development Program, which is actually an online alternative learning for the graded return demo tutorial that we usually do through actual demo of skills. But now we have to adapt to our current situation and continue to provide you guys the learning that you need to prepare you be able to give the best service during medical missions. Aside from that, this will help you prepare for the 120 points GRD in Medicine 1. I really hope that this lecture could help you compensate to the lack of demo training in person. Okay, let's start. Here's the topic outline. First, I will be discussing the important concepts for the preparation in PE, and then I will tell you the preliminary steps of PE, and then we will go through the head-to-toe PE one by one. So here are the important concepts that you have to know. First is you have to reflect on your approach. You must recognize that you are a student and that you need to train with an actual patient to really learn. And as a medical student, you must exhibit the professionalism always, even if you feel you are not yet ready. You have to accept and learn from your mistakes and failures and know that you will get better in doing PE through time. Next is check if you have this complete paraphernalia. Here you see a physician scale with an eye-level mechanical beam and the height scale. This would be used for anthropometric measurements together with the tape measure. And down here is the bed, examining bed for our patient. And also, this is an important material that must be always be present, the drape. And then this is the Snellen chart where you have to set this up before doing PE, and you have to mark the position 20 feet away from the chart. And if you don't have Snellen chart, you could use this Jaeger chart. These now are the devices for taking vital signs, the pulse oximeter, thermometer, and BP apparatus, and also the hand watch. You also need cotton for stimulating light touch and the corneal reflex. Here is the tuning fork and otoscope for ear examination, ophthalmoscope and pen light for eye exam. Here we have two amber vials where you will put the coffee and toothpaste for cranial nerve 1 testing. Here's the tongue depth for mouth and pharynx examination, the reflex hammer, and the two rulers for JVP measurement. And we would not forget the very important paraphernalia, which is the stethoscope, which is a symbol of being a doctor that we are so proud to be hanging on around our necks. Next is ensure a good lighting and environment. You have to set up the examining bed and prepare your paraphernalia on a table. In the order of sequence, you will use them. Like for example, the tape measure and the vital signs should be in the first part of the table. For this will be the first ones that you will use. And that way you will remember the next thing to do. Next, is always make sure that the patient is comfortable by securing privacy and always exhibit modesty throughout the PE. And the art of draping must always be practiced. And lastly, always explain and ask for consent before doing PE. Next is determining the scope and sequence of examination. Is it focused or comprehensive? But for your sake, always do a comprehensive PE to master doing it. And always take note to prioritize the patient's comfort and avoid unnecessary changes in position. In observing correct examining position and handedness, according to Bates, our guide to PE, it is advisable to do examination on the right side of the patient because of a more reliable estimation of JVP from the right and palpation of apical impulse is more comfortable from here. And this picture is also from Bates, and these are just symbols he used for the patient's position during PE. And we do most PE in sitting position and lying supine, and with the head of bed raised 30 degrees is used for cardiac examination. Supine for abdominal exam, and later you will know the suggested positions in each section of PE. And an important concept that is so timely right now is the observance of standard and universal precautions in light with the global pandemic of COVID-19. Standard precautions are based on the principle that all body fluids, secretions, excretions may contain transmissible infections, while universal precautions were designed to prevent transmission of blood-borne pathogens like HIV, Hep B virus, and other blood-borne pathogens. The common denominator of the two would be the employment of preventive measures such as hand hygiene, respiratory hygiene, cough etiquette, use of personal protective equipments, patient isolation, precautions relating to equipments, handling laundry, and safe needle injection practices. So we must always observe these measures to maintain safety of both the patient and us doctors, and to prevent the spread of any disease. And COVID-19 really taught us this valuable lesson. We now move on to the preliminary steps of PE. Wash or sanitize your hands before beginning the PE. You must display a professional demeanor by looking decent in your white coat and then introducing yourself politely and telling the patient you would really be grateful with their participation in the PE. And as a courtesy, address the patient with their last name. You should always consider the patient's privacy, comfort, and dignity. How so? You could draw the curtains and you must always use drape in the examination. And I'm reminding you to explain to the patient the procedures to be done and to tell them that all the palpation and auscultation must be done on bare skin. Use proper sequencing, which is head to toe, and observe proper pacing in performing the PE. And at the end, please do not forget to thank the patient. Let's go now to the bulk of the discussion. The head to toe PE would concentrate on the examination and the report of normal findings. I emphasize on the importance of mastering the normal before you could truly detect any pathology. At your level, focus more on what is normal. First is the general survey. To do that, we must employ active observation, asking the patient's name, day to day, and awareness of the place would determine if the patient is coherent and oriented. Observe if the patient is thin or looks well, or if he or she is wearing appropriate clothes for the weather. Be wary of signs of distress like cardio or respi distress. Take note of the behavior and mood of the patient, as possibly he or she could be having depression or anxiety. Or if the patient is in pain, these things are red flags that you should actively observe to be able to detect. After the survey, proceed to the anthropometric measurements and taking vital signs. You will be using the physician scale we have in the hospital to get the height in meter and weight in kilograms to be able to compute BMI with the formula kilograms over meter squared. Here you see the WHO BMI classification for Asians. Concentrate on the normal value, which is 18.5 to 22.9, which is the ideal BMI for Asians. Next, we use the tape measure to get the waist circumference. And according to researchers, the best site to take the waist circumference is at the level of the navel or above above it. Here are the normal values for men, and it should be less than or equal to 40 inches or 102 centimeters. And for women, it should be less than or equal to 35 inches or 88 centimeters. As for the BP measurement, please take note of these important points. Patients should be seated quietly for 5 minutes in the chair with the feet on the floor and the arms supported at the heart level. There should be no caffeine, exercise, or smoking for 30 minutes, for this causes elevation in blood pressure. Cuff bladder should encircle at least 80% of the arm circumference, and at least two measurements should be taken, and you have to get the average. You get first the systolic blood pressure by inflating the cuff until there is no radial pulse palpated, and then you inflate additional 30 mmHg above the pulse extinction. Place the diaphragm on the brachial artery, and as a landmark, it is at the same side of the thumb. Deflate at a rate of 2 mmHg per second, and systolic blood pressure is the onset of first Korotkoff sound. And then the diastolic blood pressure is the disappearance of Korotkoff sounds. So SBP is the onset, DBP is the disappearance. And you have to take the axillary temperature simultaneously on the other arm. And do not forget to get it when it's done. Here is the table of BP classification we use in the hospital from the American College of Cardiology and American Heart Association guideline. And the normal BP is a systolic blood pressure of less than 120 mmHg and a diastolic blood pressure of less than 80 mmHg. Next, we take the pulse rate by palpating the radial pulse and count it for a full minute. And then after that, don't let go of the pulse. But this time, draw your attention to the chest rise of the patient and count the RR for another full minute. This way, the patient will not know that you are observing his or her breathing, which could vary when they know that you're doing so. Pulse oximetry should not be used for counting the pulse rate in GRD, but it is only for oxygen saturation. Here are the normal values for the vital signs. Next is the skin. An important reminder, when we would examine something, we will always start with inspection. And that is the rule of thumb. Before touching, do a quick survey first. Always remember that. Inspection first. Take note of the color of the skin, if it is moist. If there are scars or lesions, then do skin pinch on the dorsum of the hand, and normally it will go back to its place immediately. But if you observe skin tenting, as you can see in this picture, that is poor skin turgor. For the capillary refill, apply pressure on the index finger like this and until it turns white. Then release the blood and it will return to the tissue normally less than 2 seconds. For the upper extremities, inspect for scars, deformities, or lesions. Palpate for the radial pulse at the same time and note if it is equal and ask the patient to do the range of motions for upper extremities as you can see here and observe if there is any limitations. Then check for the motor function by applying resistance to the following actions you see in the picture. And here we have the grading of muscle function and the normal grade is 5, which is complete range of motion against gravity with full resistance. For the sensory, test for light touch by using the cotton and tell your patient to close his or her eyes and point on the area where you will be lightly touching, and you have to start distally and do it at the same area on the other side and ask if it is the same quality in percentage, and when we report it as 100% sensation on both upper extremities. Then test for the reflexes in the upper extremities shown here. The normal grade would be +2. Next is the HENT examination, starting with the head. Check if the patient has evenly distributed hair or if there is alopecia. Check if there is infestation too. Inspect for scars or lesions, then palpate if there's any tenderness noted. Next is we test the sensory and motor functions of the trigeminal nerve. As for sensory, you can see here the branches of trigeminal nerve. These are ophthalmic, maxillary, and mandibular branches. So these are the areas where you will apply light touch using the cotton, as you can see here. This picture is actually wrong. Why? Because the examiner forgot to tell the patient to close his eyes. For you have to remember that every time you are testing sensation, always ask the patient to close his eyes. And for the motor function of trigeminal nerve, feel the masseter and the temporalis muscles. And when you ask for the patient to clench his teeth, because these are innervated by trigeminal nerve. Here we also do the corneal reflex. You ask the patient to look towards the opposite direction while touching the cornea with the twisted end of the clean cotton, and a positive response would be the closure of the eyes. The next is the facial nerve. For us to do this in a fast way, we do it by doing these actions and asking the patient to copy what we are doing. And being able to do this means that the nerve is intact. As for the ears, inspect if they are symmetrical and aligned, if there are scars or lesions, and then palpate the tragus if there is any tenderness. Then use an otoscope to check the eardrum and ear canal. Pull the pinna upwards and backwards to straighten the ear canal. Slowly enter the ear canal and put out your pinky finger to serve as a stop to prevent perforating the tympanic membrane. And so what you could see inside would be this. There you will see a pale gray tympanic membrane, which is not perforated, and take note of the cone of light. This is how it looks like. Also check for the cerumen in the ear canal. Next is we test the vestibulocochlear nerve. Here we first do the whisper test. Ask the patient to occlude one ear with a finger, and then the examiner whispers softly a number 2 feet away towards the unoccluded ear. If the hearing of the patient is diminished, we do the Rene's test to compare air and bone conduction. In doing Rene's test, we use the tuning fork and we make it vibrate and then placed it on the mastoid bone behind the ear. And we should ask if the sound is no longer heard, and if yes, we quickly place the tuning fork close to the ear canal and we ask whether there is still sound. Normally, air is greater than bone conduction. As for Weber's test, we vibrate the tuning fork and place it on top of the head and ask if the patient has lateralization of the sound to one ear. And normally there is none. In this picture, you could also uh, place the tuning fork here. As for the eyes, again, we start with inspection. If the eyebrows are symmetrical and even hair distribution, look at the conjunctiva. If there is pallor, check for yellowing of the sclera. Then we palpate the puncta to check for any discharge. Then we check the patient's visual acuity using the Snellen's chart. We position the patient 20 feet from the chart and ask the patient to cover one eye with a card or his or her hands and read the smallest line of print and then repeat to the other eye. If there is no Snellen chart, a Yeager chart is used instead, which is placed 14 inches away from the patient. 20/20 visual acuity is the normal grading. Next, we test the visual field. We assume the proper position by sitting in front of the patient and asking the patient to look into the examiner's eye. Then we test the visual field quadrants of the eyes, as you can see, and by moving the fingers and asking the patient if he or she notices it as you do. And if both you and this have the same observation, then the patient has a normal visual field. Next is the pupillary light reflex and accommodation. Here we use the pen light where we shine a light obliquely across the eye and observe the direct and consensual light reflex. Then as for accommodation, we ask the patient to focus on your finger or at the tip of a pen light and then bring it near to the patient's eyes. There you will see the pupils constriction as well as uh, it is positive for accommodation. And this is represented by perla, which means pupils are equally round and reactive to light and accommodation. Then we check for the extraocular movements. High yield info is that all of the rectus muscles are innervated by cranial nerve 3, except for superior oblique and the lateral rectus. These are innervated by cranial nerve 4 and 6, respectively. We ask the patient to follow the tip of the finger or pen light with their eyes only and keep their head steady as you sweep through the 6 cardinal directions of gaze. Here, for example, you start at the center and then you sweep sideways, okay, and then go back to the center and then do the X pattern like so. Go back to the center and then other side and then center. So these are the 6 cardinal directions of gaze. Then lastly, for the eyes, we do fundoscopy. Please note that you have to turn the lens disc of your ophthalmoscope to 0 diopter and then hold it with the right hand to examine the patient's right eye and hold it in the left hand to examine the left eye, as you can see here. And also, this should be done in dim light so that you'll be able to detect easily the red-orange reflex, which you could see 15 inches away from the patient. And once you see that, approach near the patient until you will be able to appreciate the optic disc. And here's the normal structures that you would see upon fundoscopy. Next, let's examine the nose and paranasal sinuses. Inspect first the anterior and inferior surfaces of the nose and push it gently on the tip to widen the nostrils, as you can see here, and also tilt the head slightly. And you could use the otoscope with the largest speculum to inspect the inside. Check for the nasal septum if it's at the midline. If there is inferior middle turbinates inflammation, take note if there are any discharges. And then here you see the palpation of the frontal and maxillary sinuses, taking note of any tenderness. These pictures were taken from previous GRD tutorial of Momfy from our batch. Next, we test the sense of smell. Ask the patient to close his eyes and then cover one nostril and then place the vial with the odorant like coffee or toothpaste and then ask the patient if he or she can identify the odor. We go now to the mouth and pharynx. We start by inspecting the lips, oral mucosa, and tonsillopharyngeal wall using pen light and tongue depressor. Also inspect the gums, teeth, and hard palate. Stimulate a gag reflex by pushing slightly downward the tongue depressor and ask the patient to say ah to test for glossopharyngeal nerve and vagus nerve. Taking note the position and symmetry of the palate and uvula at rest and with phonation. Then ask the patient to put out his or her tongue, then move it side to side to check for hypoglossal nerve. We now examine the neck. Inspect first the trachea if it's in the midline, and then check for thyroid enlargement. You have to go to the back of the patient and then palpate the thyroid gland as you can see in the picture, and then ask the patient to swallow. And then now for the lymph nodes, palpate for it starting here at the preauricular, going to the postauricular, to the occipital, then tonsillar, to the submandibular, then submental, then the superficial cervical, and then the deep cervical lymph nodes. And then lastly, the supraclavicular lymph nodes. And you have to note if there is any palpable lymph nodes and tender lymph nodes. Then we test for the spinal accessory nerve by testing sternocleidomastoid against resistance and ask the patient to fight the push you are applying to the patient's face. Then we also test the trapezius muscle. Again, apply resistance by doing shoulder shrug and your hands pushing it down. We now move on to the examination of the chest and lungs. Here we follow the sequence IPAPEA, which stands for inspection, palpation, percussion, and lastly, auscultation. Take note to prepare the use of drape in covering the anterior thorax because in inspection, the posterior thorax should be fully exposed. Inspect the cervical, thoracic, and lumbar spine. Palpate the spinous processes and check if the spine is at midline. Inspect the chest movement and shape. Then place your thumb at the level of the 10th rib with your finger loosely grasping the rib cage, and then you gently slide them medially, as you can see here in this picture. And then ask patient to inhale deeply and observe whether the thumbs move apart separately. Next is palpation of the tactile fremitus with the ball of your palm or ulnar surface of the hand. Ask for the patient to repeatedly say 99 while you palpate both sides simultaneously. So here we have three sites of tactile fremitus palpation, the high, mid, and low. Next is percussion. Please do not forget to tell the patient to keep both arms crossed in front of the chest while percussing. And here's how you should percuss. You press with the left middle finger against the chest wall and strike it with the right middle finger. Percuss in these 7 areas on the posterior thorax with a stepwise ladder pattern going down from here and then back here, down again, then back to the other side. And with the patient instructed to breathe deeply through an open mouth. And in here, uh, at the examination of the posterior thorax, we could already do the kidney punch. And you have to detect any costovertebral angle tenderness. Then we go now to the anterior chest. Inspect the shape of the patient's chest and movement. Palpate for tactile fremitus. Here are the sites for the anterior thorax. So there are 3. And then percuss and auscultate on these 6 areas. Please do study the different breath sounds online, and there are many videos on YouTube regarding it. Next is the cardiovascular PE. Prepare the following: your 2 rulers, the pen light, drape, and put the examining bed elevated at 30 degrees, the head part. Remember to be on the right side of the patient when you are examining the heart. For the JVP, look for the angle of Louis, and it is here between the manubrium and the body of the sternum. Then trace the pulsation with the ruler, and that should be less than 3 to 4 centimeters to be normal. And then look at the carotid pulsations and listen for carotid bruits. And we will use the bell of the stethoscope for this. For the precordium, look for the apical impulse by inspecting the pulsation at the apex by shining a light obliquely. And then palpate the area where you saw the pulsation using the palmar surfaces of your fingers to locate the point of maximal impulse. As you can see in this peak, PMI is normally at the 5th ICS left midclavicular line, while the right ventricular impulse is along the left sternal border. As for the auscultation of the heart, we use both the bell and diaphragm. And to remember the sequence, we use the mnemonic ape to man. From the aortic at the right second ICS, and then pulmonic At the left, second ICS, the tricuspid. At the third or fourth ICS, and the mitral. At the left lower sternal border, fifth ICS. And if you would notice, it has a Z pattern from aortic, pulmonic, tricuspid, and mitral. It's letter Z. So you could do the bell first, downwards, and then go back with the diaphragm. We now move on to the examination of the abdomen. What is shown here is the proper position of the patient, which is in supine with the arms at the sides and the knees are flexed. And we adjust the drape to cover the anterior thorax, as you can see here. For the abdomen, we follow the sequence Iya Pepa. Okay, remember that Iya Pepa. But for the lungs, it's Ipapea. Inspect the abdomen if it is flat, flabby, globular, or scaphoid, and if there are any scars or lesions. Auscultate using the diaphragm of the stet for bowel sounds in one spot, and that would be sufficient already. And then check for aortic bruit just above the navel, and then we percuss the abdomen uh, in the four quadrants. After that, we percuss for the liver dullness. For the lower edge of the liver, you start percussing below the umbilicus going up. So you should note for the transition of tympanitic to dull. And once you reach that, that would indicate the lower liver edge. For the upper edge, start at the area of lung resonance, mid-clavicular, going down until you reach dullness, indicating the upper liver edge. And we use the ruler to get the vertical span value in centimeters. And here are the normal values for liver span. At the mid-sternal line, it's 4 to 8 centimeters, while at the right midclavicular line, it's 6 to 12 centimeters. And then we percuss also for the spleen at the left lower border. And costal margin moving laterally. After percussion, we do palpation of the abdomen. First is light palpation using one hand in four quadrants and also in the suprapubic and epigastric areas. Then after that, we do the deep palpation using both hands. We then palpate the liver edge, as you can see here, using the hooking technique here below. And we ask the patient to breathe in. After the liver edge, we palpate next the spleen tip, as you can see here. We do this by reaching over and around with the left hand to support and press forward to the lower left rib cage, and then press inward with the right hand, as you can see here. We now go to the lower extremities. Start by inspecting the legs, feet, and joint. Look for edema and other deformities. Then assess the edema by pressing on the shin of the patient. And if there is depression like this, then that is positive for edema. And then you palpate for the femoral, popliteal, and the dorsalis pedis. and posterior tibialis pulses. And these should be regular and non-bounding. Then test for the range of motion of the patient by performing these actions like flexion and extension of the knee, and there should be no limitation nor tenderness. Shown here are the ways to test the muscle strength of lower extremities against resistance from the hip to the knees and the toes. As for sensory, like in the upper extremities, test also for light touch, on this time for the legs. Then we do these reflexes. The patellar. The patellar reflex is best done with the legs dangling, while the ankle jerk test can also be done standing with the side to be tested flexed at the knee, rested on a chair. And lastly, check for the cerebellar functions by instructing the patient to do finger to nose test, heel to shin test, rapid alternating movements of the hands, palm up, then palm down, repeatedly. And then lastly, we check the gait of the patient and we observe if the patient has any varicosities on his legs. Instruct the patient to walk along a straight line normally and then using the heels away and then the toes going back to his previous place. Here are the must know normal values that you have to memorize. And please watch actual demos of the tests I have discussed for you to better understand. And also be familiar with the normal breath and cardiac sounds. You can search all of these in YouTube. And well, that's it. And I would like to end my presentation with a quote from my previous debate mentor, Kuya JM. Here it goes. Medical school is not a place for smart people, but for those who are insane enough to dream of it, pray for it, work hard for it, and live for it. It is for those who are crazy enough to want the sense of purpose that fuels their veins. Continue to keep your passion in learning, and no matter what, keep dreaming on. It is our attitude, more than our aptitude, that will determine our altitude in life. Thank you for listening and have a good day.